Good afternoon, everybody. Thank you so much for attending the FORTE workshop. We have a real bang-up agenda ready for you. It is my great pleasure to introduce Dr. Larry Wickerham. Dr. Wickerham has worked with NRG Oncology for, 30, 40 years, and he has retired just recently, but he has a real unusual perspective going back to the days of Bernie Fisher and prevention trials, and we thought he would be an incredible person to open our session, and so please welcome Dr. Wickerham.
Well, thank you, Rocky. That's very kind of you. Welcome, everybody, to Florida. As you've heard, I am indeed retired. Thank you very much. That means I get to read novels instead of medical journals and grants. I get to play golf. I played golf yesterday, 18 holes, 18 today already. We had to tee off at sunrise. And I honestly can't remember the last time I had to wear a coat and tie. The retirement came relatively soon after the NCI approved NRG to conduct the FORTE study. But I'm going to tell you a little secret. Not long after I retired, I had a routine screening colonoscopy, and it identified a small, low-grade adenoma in my distal sigmoid, and all of a sudden, I was a potential participant for the FORTE trial. The gastroenterologist that did the study actually trained with Dr. Schoen and recommended that I have a follow-up colonoscopy in 5 years. However, I began to lobby to become the first participant to be randomized into the FORTE trial. And my next remarks are going to be from the perspective of a potential participant. I liked the design, relatively straightforward, 5 years or 10 years. And certainly if 10 years proves to be equivalent, we're going to expose less people to the uncommon but occasional complications related to colonoscopy. The costs will be less, and I'm talking cost to people undergoing colonoscopy. Even if you have insurance, there's out-of-pocket costs, even if it's just parking or a day off work. And I certainly like the idea that I would have not required additional testing, no x-rays, no lab work in order to be randomized into the study. And the follow-up seemed very attractive. It was annual follow-up. It didn't even really require a face-to-face study. It was just sort of a disease status check. And in all honesty, I like the idea of potentially contributing to the next generation of individuals about the proper interval for colonoscopies in people like me. Unfortunately, the pandemic hit. The trial got delayed. And in the interim, I turned 70 and was no longer eligible for the FORTE trial, so I was not the first participant. But FORTE is now open, as you're aware. Accrual is occurring. It's okay, but it certainly could be better if we're going to complete the entry phase in a timely fashion. And we need more sites who are already accruing, already active, to begin to accrue actively, and for those sites that are accruing, perhaps to do it a little bit better. No study is easy to conduct, no matter what anybody tells you. I've been doing this for a long time. The activation process for NCI studies, as you're aware, is challenging at best. Even the annual renewals are a nuisance. And I recognize that NRG is an oncology group. The leadership, both nationally and locally, are oncologists. It's only normal for there to be a bias focusing on cancer treatment trials. However, NRG and its legacy groups has a strong history of successfully conducting cancer control and prevention trials as well. And the FORTE trial can be a relatively easy way to achieve your required cancer control activities. No study is easy to enter large numbers of patients or participants. For this study, you need GI docs who are willing to participate to identify potential individuals for the study and to set up the local logistics. And that can be a real difficult thing to achieve. But during this meeting, you're going to hear how some sites have successfully overcome those burdens. You also, in any prevention or cancer control trial, can end up presenting to a lot of potential candidates and maybe get 1 out of 10 who actually enter the trial. And that can be frustrating to you, especially if there's somebody looking over and trying to make decisions for resource allocation. But as you present any trial more frequently, you get better at it and you're more successful, and more of your potential candidates go into the study. But again, during this meeting, you're going to learn from sites, hopefully just like yours, on techniques that they've begun to use to be successful in their accrual phase. NRG is a large group, and there are a lot of cancers and centers and universities. And what works at a large university for this trial may not be appropriate for your center. But you're also going to hear, in NRG we have a lot of non-academic centers, a lot of suburban sites, even rural centers, and hopefully you will hear from them on their techniques that match your potential needs. It is my experience that this trial is doable. I think that's the take-home message. FORTE is a doable trial, and also can assure you that there are lots of potential participants just like me who, if given the opportunity, will enter this study. And I certainly hope you will do that. Enjoy your time in Florida. I think I'm going to go back and practice my putting, which needed a little work this morning. Thank you very much.
Thank you very much, Dr. Wickerham. My name's Jeff Duker. I'm a gastroenterologist, and I know we're at an oncology meeting. You're about to hear from a lot of non-oncologists, like gastroenterologists like myself, and it's also prevention, so I think it works on multiple levels. See if I can advance here. There we go, thank you. If this doesn't work, I'll just say next slide. So I assume most of you already know what FORTE is all about, but I am going to briefly go over the trial. So if you have a colonoscopy and you're an average risk person and you have no polyps, we're recommending repeat screening in 10 years. A colonoscopy where you have 1 to 2 non-advanced adenomas, the recommended repeat surveillance exam is between 5 and 10 years. This depends on the pathology of the polyp found, whether it's a tubular adenoma or a sessile serrated adenoma. And the range actually is 5 to 10 or 7 to 10, depending on the type of polyp. But still, there's a range, and both of those ranges include 10 years. The issue with this is it seems that patients with no polyps have the same colorectal cancer risk in future years as patients with 1 to 2 non-advanced adenomas. This is a graphical representation of the same statement, and you can see here that those with non-advanced adenomas on 15-year follow-up have the same colorectal cancer risk as those with no adenomas. So you might say, okay, we're done. We know exactly what the follow-up interval is for patients with low-risk adenomas. However, multiple caveats. The patients in the adenoma group had more colonoscopies done. That's because more colonoscopies were recommended, so more of them got done. And then on those colonoscopies, more of those patients had polyps found and removed. So are these two groups equal because they have equal risk, or did the intervention of additional colonoscopy and polyp removal result in the equal risk? We don't know. That's why we're doing this trial. So this is the general schema. We're taking patients with 1 to 2 non-advanced adenomas. We're looking for 9,500 patients. It has to be their first colonoscopy identifying polyps. We're randomizing them to surveillance colonoscopy exams at 5 and 10 years, the top line, and a 10-year exam. And we're using colorectal cancer incidence as our primary endpoint. with a non-inferiority comparison. But this isn't really how we're constructing the trial. We like to think of it more this way. So there's how we think about traditional recruitment for trials. A colonoscopy happens now or after now, and they have the required findings on colonoscopy, they're randomized. However, we can look back to colonoscopies performed up to 4 years ago. This increases the potential eligible patients by a large amount because there's a huge pool of people that have had this finding. And by the way, this is present in millions and millions of people across the country. So going back 4 years, we're hoping you can randomize someone for their next exam, their 5-year exam, which is actually maybe 1 or 2 years from now. It's important to note that we're not doing this in a bubble. All 3 of our major societies, ACG, the AGA, and the ASGE, support the conduct of this trial, and they agree that it's the most rigorous and authoritative study designed to answer this particular question. So really that's the reason why we need to do the big trial and why we need a bunch of patients and your help to get it done. We hope to argue that FORTE is very user as in NRG site friendly and participant friendly. A lot of initial enrollment forms are filled out by the participant. There's a yearly follow-up, as Dr. Wickerham mentioned, and there is an opportunity for participant blood and stool collection, which we're trying to streamline, and sites are also given additional funds for having patients collect those. We really want to emphasize that finding the correct eligible patients can be a challenge. There's millions of colonoscopies. Even a particular site may have thousands and thousands of colonoscopies that their gastroenterologists or colon cancer screening physicians do. And use of natural language processing can really help cull down a big list into a much shorter list of potentially eligible patients, which you can then review and basically less work up front to try to find the right people, less chance they're going to be excluded. And this is available for no additional cost to your site. I'm also just want to mention too that Spanish language forms for everything are also on their way and will be a part of this trial, an important part of this trial. The key here has been alluded to is really a partnership. Really partnering with a GI practice is critical, and we hope to really focus on this today and give you some examples of this. And it's with that I actually want to bring up my colleague, Dr. Erdem, to talk more. Thank you.
All right, thank you, Dr. Duku. All right, so I'm going to briefly talk about why am I interested in FORTE trial as a general gastroenterologist. So before I do that, I need to explain to you who am I and where I work. Obviously, I work at Spartanburg Regional Healthcare System, and we have about 6 hospitals that are located in the upstate South Carolina, and we are the largest hospital group in that region. In our GI department, we have 8 GI doctors and 12 mid-levels, and we do about 26,000 office visits and 23,000 procedures in a year in our office. So going back to those numbers, you can say this is a real-world experience where most of the general U.S. population gets their routine GI healthcare. And because of this, I believe sites like ours should be represented and play a vital role in the FORTE trial. And there are many, I know, practices like ours are present throughout the country that can participate that have high volumes in the FORTE trial. So why I want to participate in FORTE? I mean, the first answer is easy, obviously. As a general gastroenterologist, my day-to-day practice involves a lot of screening colonoscopies, and obviously we're going to have the answer of what is the appropriate surveillance for 1 to 2 small tubular adenomas, as is mentioned earlier. It's also a low-hanging fruit because it is really easy to participate. Again, I'm going to tell you about my experience as a general gastroenterologist in an academic center so far. And it really has no time commitment from endoscopy standpoint. If you're approaching a general gastroenterologist in your site, you can really prove that with this presentation. So far, I spent my personal 3 hours either on the driving back home or during these meetings, that kind of got where we are so far. And obviously that comes because I had a luxury to participate and partner, as Dr. Duker was saying, in the NCORP upstate group that did the hard work for us. So just want to talk to you about a little bit our partnership. So Upstate Carolina and NCORP, again, working in my site, I have the luxury to have access to this community oncology research program where we serve 13 countries and 3 affiliate sites, and we have about 48 investigators in our site. It's a multi-PI structure, and again, I'm one of them right now. And we have many clinical trials, obviously, in our site, but this is our FORTE specific trial team, and I became the site PI as a general gastroenterologist, and we have an amazing team who are here with me today, Melissa, Kamara, and Jeannie. They do the hard work, and kind of, they're the reasons, obviously, we got this working right now. So, I mean, in this presentation, I wanted to give you a timeline and what we started and where we are right now, so that gives you an idea, if you are thinking about starting the FORTE, how the process works for you in a non-academic center. So obviously, our NCORP site was interested in participating in a FORTE trial. That interest started in 2021, and I joined Spartanburg Regional in 2022. And after that, I kind of obviously trained by Dr. Schoen, automatically my interest sparked, and I wanted to also participate in a FORTE trial. And that introductory meeting was about an hour. I learned about NCORP, and I asked questions, how does it work, and what do I do, what are my responsibilities? So all of them were answered very easily, and we decided to proceed with the trial. And after that, we asked, as a team, Dr. Schoen, our study chair, to present the FORTE trial to my practice and my partners, and on a Zoom meeting, and they also answered their questions, and we got the answers, and we decided we want to participate in the trial. So that was in October, and then we started working on it. Again, our amazing team has been doing most of this work, where they did the protocol review, workflow, and we worked with our local EPIC IT groups to look at the streamline, and obviously I was listed as the CTSIU new investigator. We are right now waiting on the only caveat so far has been we're ready to launch, except we're waiting on NCI IRB submission. As mentioned, that could be challenging sometimes to get approval. So that's the last step so far. And then, as you can tell, Dr. Duker also said, this trial allows you to go back and recruit patients who already had colonoscopies within the last 4 years. So that's a great opportunity. And in our side, having about 20,000 procedures in a year, that equals 80,000 potential procedures to review. So that you can think about, it requires a lot of manual labor. So to cut down, obviously, for the trial design, thought about it, and there is a third-party company that they're partnering pieces that we're hoping also partner that uses natural language processing system that we will provide them our colonoscopy reports and the pathology reports, and hopefully they will give us the eligible patients that we can reach that will cut down our manual labor. So that's kind of the timeline. Again, we started from August, and here we are. We're about to be activated as a site with a lot of potential patients. And I just wanted to, again, emphasize sometimes the GI docs, obviously different from oncologists, that you can say, okay, there's this GI guy in the South Carolina spent 3 hours and they're ready to be activated. So you can use that and most of that time is in the driving. So that's one thing to talk to them about. So last thing is I wanted to mention the question about, okay, is there a revenue loss potential? We're doing 5 versus 10 years. Is there anyone who's concerned about this? As a GI doc who just started, obviously, practices, I still have, obviously, student loan debts and mortgage payments. Those are still concerns. And those are the ones that stands behind that before I get my private pilot license, flight license. But these are, again, joke aside. This, in a nutshell, I wanted to tell you, as a gastroenterologist who work in the community, is so far my experience has been it is easy to practice. Once you partner with the team, outstanding team like in our NCORP, NRG site, You don't have a time commitment, and it is really a low-hanging fruit. Why not participate in the FORTE? With that, I would like to thank Dr. Schoen and Dr. Duker for giving me this opportunity to present our experience so far. And I would like to thank, obviously, our team in the site, Melissa, Kumar, and Jeannie, for making this easy for us. Thank you.
Thank you to everybody. In fact, I really wanted to start by thanking the incredible NRG team that I'm working with, Christine and Cheryl and Martha Duncan. And I also want to thank all the coordinators that are out there and their helpers who have started FORTE. And to the coordinators who will be starting FORTE, we really appreciate what you're doing. I wanted to make a point. This is a practice-changing study. This is a study that is really going to change the landscape because we're doing a lot of surveillance colonoscopy. We're not sure that it needs to be done, and it really takes this kind of a definitive randomized trial to change practice. And so you, in being part of this, you're being part of something historic and meaningful, and we really, really appreciate your interest, and we hope we can convince you to be a part of this. I wanted to talk about FORTE strategies for recruitment. You know, Furkan and others said the first step is establishing relationships with GI doctors. Why? I doubt anyone knows who this person is. I had no idea what he looked like, but this is Willie Sutton. And Willie Sutton was a bank robber in the 1930s. And they asked Willie Sutton, Willie, why do you rob banks? And he looked, he goes, because that's where the money is, okay? And that is an aphorism that we apply to medicine. Many times when we think, why are we going to do this procedure or that procedure, we think, this is where the yield is, okay? And so the yield in FORTE is going to the doctors that are seeing non-advanced adenomas, and those are your gastroenterologists and surgeons who do endoscopy. We will help you with getting endoscopist participation. I have participated in a number of 7 a.m. meetings with GI docs in various communities, talking to them about FORTE, and we will certainly give you our time to help you win people in your community to this goal. Why should a GI practice participate? Again, Furkan started on this. It's an opportunity to be a part of a landmark trial. Is the trial putting patients at significant risk? This is an issue because you're saying, wow, you're going to wait 10 years? Well, the truth is the 10-year follow-up has been part of guidelines since 2012. So over 10 years, we've had in the guidelines, you can do a repeat at up to 10 years. We know that 1 to 2 non-advanced adenomas are low risk. We're finding more and more of these tiny little adenomas, and we're not certain of their significance. And remember, if a patient has a clinical indication for a colonoscopy, they get it. We are not standing in the way of needed clinical care. We are not interested in putting people at risk in that regard. What about revenue concerns? Furkan kind of was funny in talking about this. I explained, look, only a small percentage of your patients are going to agree to be part of this trial. Half of them are going to get the 5 and 10-year exam. And the lost revenue that you might think if you're losing that 5-year surveillance may be offset by the improved compliance, because we're going to be following people every year and encourage them to comply with colonoscopy. And I assure you, people don't necessarily follow what you've told them to do in terms of coming back. The Multi-Society Task Force, these are the people that made the guidelines that currently say come back in 7 to 10 years. They have fully on board. They're documented to say we fully support the FORTE trial. What are some strategies that you might employ? Well, one thing that we've started to do is what we call a travel allowance. We understand people are busy. They don't necessarily want to come into a center. Even though I will tell you that at my center, and we have enrolled 70 people in the FORTE trial, we have it down to 1 15 to 20-minute visit. They're there and they're out and they're done. But we still now have been authorized by the CIRB, and other sites are starting to glom onto this. We can give them a $40 travel allowance as an incentive to come in. And we think that's going to be helpful, and it's certainly something to consider, especially in rural areas. This study has very minimal patient burden. A few questionnaires, a stool collection that they do in their home at their own time, a single blood draw. The yearly follow-up can be remote, so in fact, you may just have one visit live with that person, the initial visit, and we're even moving now to potentially an e-consent where you didn't even have any personal visits. That's on the table and it's being discussed and piloted. Look, you have to send a lot of letters, or you got to do a lot of phone calls, or you do both. There's no question, it's a little different model. It's not like, oh, here's someone with a cancer of this stage and this situation, and they qualify. This is a case where we got many people who qualify. Again, we just need to get it out there, and even if it's only a small percent that agree to be part of it, we can still recruit big numbers. We've mentioned the natural language processing, and many practices use electronic records to record their colonoscopy exams and pathology exams. We've contracted with this outfit that is first class. They understand the HIPAA issues, they understand the data issues. They can work with your site, take your records, crunch them, and get them back to you. And that way you can just focus your letters and phone calls on people that are highly likely to be eligible. You still have to ferret out a few things. It's not a perfect screen, but it will take you a long way to getting where the money is. This is my little schema of the NLP. You see, you have all these colonoscopy exams. They put it through the funnel of the NLP, and they tell you, here are the ones that look like they have 1 or 2 non-advanced adenomas. Focus your attention there, get people enrolled. We've created a network fee. This is a $5,000 one-time startup fee. We recognize you may not have connections with GI doctors. You may not have done a study like this before. We're happy to give you upfront monies to get you rolling, and that way you can hit the ground running and then get your per patient reimbursement. You have to fill out a form to get this. It has to pass some muster, but we've got many, well, I would say many. We have, I don't know, 8 to 10 sites that have already done this, and I expect many more in the coming days. This is the enrollment as of 1/19/23. You can't read that, but it says 332. You can see we have 3 sites that are doing a lot of work, but we've got a lot more sites that are coming on board and are starting to get the message and get it out and getting rolling. And I am really optimistic that we're really poised to gin up our recruitment. I will tell you this, between January 4th and yesterday or the day before when I looked, we had recruited 41 patients in 3 weeks, the first 3 weeks of January. Okay? Now, that's not enough, but that tells you people are willing to participate in this trial, and you have an opportunity to participate, and we all have an opportunity to make a difference. Thank you. Okay, we are now going to move to a panel discussion where you can hear from people who are really on the front line and doing the work for the FORTE trial. I think I'm going to let you all introduce yourselves, tell us where you're from, and then we'll get it rolling.
Hi, I'm Nicola Thornley. I'm from the Ralph H. Johnson VA in Charleston, South Carolina.
Hey there, I'm Jamie Saunders, and I'm a research program manager in oncology from Maine Health.
Hi, I'm Jody Gear. I'm Metro, Minnesota.
Well, I guess I'll kind of give you our outlook on Forte. I can tell you a little bit about my site. Maine Health, where I'm from, treats about 1.1 million people and covers about 9 health systems. So and Maine's a really rural state, and we only have a population of 1.4, so Maine Health covers a lot of those patients. It's one of the more rural states in the country, actually the most rural, even more rural than Alaska. I didn't believe that, but I did look it up. So my goal was we wanted to include gastroenterologists and patients from throughout the state and throughout our network. And when I looked at this, I'm like, oh gosh, the logistics of that are kind of overwhelming. So how did we manage this? And how do we think we're going to make it successful? So not too long before we enrolled our first patient, we had created a team. And it's a team of coordinators who are cross-trained over a number of studies and can be deployed to a number of our sites. So if I have somebody going up to Penn Bay, which is a 3-hour ride, how can we make that trip efficient? So we make sure they're cross-trained, and we really concentrate on the teamwork. We were engaging our gastro practices. We requested, AKA begged, for time on their monthly provider meeting, and we sort of did a road show. We had Dr. Schoen present at one of those, which was really helpful. His enthusiasm is definitely contagious, and it really helped get that site on board. We utilized existing connections. An introduction from somebody you know to somebody you don't know really helps pave the way. They may actually open that email. We tried to engage at least 1 to 2 docs at each of the clinics to sort of be the champion, because you have one, and you may or may not get more, but that's okay. If you have one gastro person who's really engaged, that might be all you need. We have regular and ongoing research. And the message that we give to all these sites is we're a one-stop shop. So you refer the patients to us, and we pretty much take it from there. So that takes the onus off of the clinic. We've also done a bunch of community engagement. We have some really great community cancer organizations, and we've engaged them and done presentations for them. And kind of the one-off, which is really interesting, I think, is we've been able to engage with the private practice. To help, here's Maine Health. We also done a private practice, and they've been really enthusiastic. They haven't enrolled a patient yet, but they've been enthusiastic, and I'm looking forward to them enrolling their first patient.
We definitely want to use this time for questions as well, so please feel free to come up and ask any questions you have of our coordinators on conducting the Forte trial. And if you are virtual, you can also pop into the chat. We do have a moderator who is happy to read your questions out as well.
I will say I did have one question from the town hall meeting. Somebody typed in that didn't get answered during the meeting, but they were questioning about getting to your GI department. Do you need to get your entire GI department on board? No, you don't. How I did it was the GI department head as my first contact, and then getting the okay from them, and then reaching out to each individual GI, getting their individual consent and moving from there. So the whole department does not have to be on board. If you have one GI doc that wants to do it, or if you have the whole team, either way works. So it doesn't have to be the entire department.
I do have a question, if that's okay. And it goes back to the network reimbursement payment. Is that only available one time per NCORE, or is it available per network? So let me give the example. Within our consortium, we have 24 different sites, which are probably about 9 different kind of healthcare entities. And so in opening up the trial at some of these different sites, it would take kind of ground roots at some of these different healthcare entities. So is it, I just wanted to understand a little bit more about that potential reimbursement.
Can you, oh, I am on, wow. It's one per network. Michelle, is that you? I can't.
Yes, it is.
Gosh, I know that voice.
Sorry, I didn't introduce myself.
Well, that's all right. I know your voice.
Like, say, for instance, we have 24 different NCI site codes within our consortium, right? And so some of them are truly different networks. So I guess I need to learn more about.
And you and I can talk about this on the side, because your situation's a little bit different than some of the others.
Okay, great. Thank you.
You're welcome. It looks like Dr. Ford has a comment. Okay, just checking, sorry. I have a question from the chat. A site is asking, I know you need a GI champion, but does the GI need to go through CTEP certification? If the GI doctor is referring patients to the NRG site, where the NRG site's going to be the one putting the patient on, following the patient and all that good stuff, then the GI doc doesn't need to go through CTEP certification. If the GI doc is going to be the one putting the patients on, following the patients and all of running the study essentially, then they would need to go through the CTEP certification.
So I'm Melissa Faust from Upstate Carolina NCORE, specifically from the Spartanburg site. And I was hoping that the Metro Minnesota representative would give a synopsis of how they've been so successful, because our coordinator is actually here now. That presentation was awesome in the NCORE Town Hall. So.
I guess it just takes a lot of time and patience. You're going to screen a lot of patients, and a lot are not going to be eligible. And then from the eligible ones, there's a lot of no's because I want to have my 5-year no matter what. So it's patience. I think we came up with about 7%, did we say? Yeah, about 7% of the patients that are eligible actually go on study. So it's just take it first little baby steps, especially if, I mean, for me, it was a whole new area of research that I've, really never done. So we started out small, and then, as we get all the wrinkles out and continue to move forward, the easier it gets. So just don't expect a huge number right off the bat. Just get your process down, make it simple, make it easy, and then continue to grow from there. Once you have that process down, it's pretty easy. It's not hard at all. So does that help?
You actually want to take it slow because the first couple are so confusing. So I agree with that completely.
I have another question from the chat, and this is for the physicians at the head table. Do you have any pushback from the gastroenterologists regarding the updated guidelines? I know there is a letter of support, but the bottom line is the guidelines were already updated. Do one of you want to address that?
Yes, so the guidelines were updated for 2 small tubular adenomas to be 7 to 10 years. Interestingly, the Sesshaus-rated adenoma, which is less common, but that is still 5 to 10 years. The truth is those guidelines were updated based on the arguably inferior observational data that we've already presented, which is why we're doing the trial. The other reality is many patients, going back just a few years, these new guidelines were published 2.5 years ago, I think, at this point. So going back, there are still patients that are being told 5. And I actually just read a study looking at a lot of practices' compliance with recommending 7 to 10 over 5 to 10, and compliance with that recommendation is actually very low. So that's not good, but in some ways I think it just shows you that there's a lot of equipoise around what the correct interval is, and it just highlights the underlying need to do this trial. So that's exactly what I would tell a gastroenterologist, and that's exactly what I would tell a potential participant. Dr. Schoen or Erdem?
I mean, in my side specifically, most of the people I find, obviously for the recommendation, there are a lot of other details goes into how comfortable you're with the exam that you did and all of it. Thinking an optimal exam, I found my partners and myself sometimes really going into rabbit hole of 5 years versus 10 years, and it's kind of anxiety provoking, and that's one of the reasons that actually my partners are willing to participate. So I think that kind of knowing that this is a well organized study, that if you present in that way, there's still a lot of GI docs. When I write my report in the end, okay, next colonoscopy, I pick a number. I mean, that's that simple. I mean, right now there's a wide range, so you can argue with your GI doc why 5 versus not 10. We don't have the answer, and this is what's going to happen. So,
I'll just add. I tell the GI docs, if you believe that 5 years is the right interval, then you should be putting your patients on FORTE. Why? Because the interval is being pushed out. There's pressure to say, oh, we don't need it. Let's do it later. Let's do it later. And the only way to know if the 5-year really makes a difference is something like the FORTE trial. So if you're a believer in the early interval, you should be the first one to be putting your patients into this study.
Good afternoon. Christina Gardner with Cancer Research for the Ozarks. I want to step back to the question about enrolling patients, which doctor we put them under. If we go ahead and accept that we're not going to get our GI docs to go through all the city training and the other pieces that we'd have to have them do for CTEP registration or NCI registration, then our sites are asking, can we enroll under APPs? And even if we're enrolling under our med-oncs, is it okay if those patients are never going to see those med-oncs and they're not going to follow them? Can we still register under them as the treating or registering investigator?
That's what we do. It's not been a problem, and I think Nikki agrees that that's the way their site does it as well. They don't ever see them, but they do sign off on the checklist. And APPs, we've been using those as well.
Thank you.
I just want to emphasize, every site that I know of in this study is doing it with nurse consents or APP consents, and it is not necessary to have the doctor in the room at the time. Of course, they're made aware that if they need to contact someone, if they want to discuss, we're open to that, but they do not have to be present at the time of consent.
Actually, on that note, we don't ever, I've never had the doc in the room with the consent. We've done them, all of ours have been exclusively remote, and then we just have the checklist signed off by either the oncologist or the APP.
That's what we do too. I send the provider, I have 2 med-oncs that I use. They never once see the patient, but when I send the eligibility checklist, I also include an H&P procedure report and a pathology report, so they are, they can look at that. And they also have access to their actual chart too if they need be, but it just streamlines their time to sign off, so they've never seen the patient at all.
Hi, I'm Kamara Mertz Rivera with Upstate Carolina NCORE, and as you've heard, we're working diligently on opening this study. And I do want to ask a little bit about the NLP program pieces, I believe. How do you get your site, if you have it running at your site, how did you get your IT or your group to participate? Because I think that might be one of our challenges. And I also heard Metro Minnesota mention they have a report. What's the secret sauce to finding, refining that report would be my question. Thank you.
In regards to the PISA NLP, you can reach out to FORTE at nrgoncology.org. That's the dedicated email address for the FORTE study at the NRG Ops office in Pittsburgh, and we're more than happy to send you information. We have specific contact at PISA that we work with directly, and we can definitely schedule meetings and get your IT people connected to their IT people to answer any sort of security, data security requirements that will come up in conversation. So.
We don't actually use that, and I don't really have a secret sauce. It's just the guy in pathology. He's awesome. So, yeah, like I said in a town hall, he made his own report. He's one of the very, very few people that have done that, and I don't know how he did it. I don't know, but I'm just very grateful for him.
Yes, I just speak. I have worked with Pieces now for probably over 1.5 years. They are a first-class outfit. I couldn't speak to your IT people, okay? Pieces can speak to your IT people. They understand what their concerns are, the HIP issues, the security issues, and I intentionally, you need to talk to them, reassure the IT people. It's the IT people that have to talk to each other and come to an agreement. Now, it's true, some of these IT people are not very flexible, and this is something we have to just keep working on. But I can assure you, Pieces is a first-class outfit that understands all of the issues, and they know how to address them.
Oh, real fast, sorry. I was just going to speak quickly to the non-pieces patient selection. It's very individualized, but different systems, different health record systems, there are ways to try to find these patients just using internal systems like we were hearing about. And we've actually had several meetings with sites about this. So we're willing to try to put the pieces together between what's available at your site, what kinds of things you need to look for, sort of lend our gastroenterologist expertise into refining an internal system in addition to using pieces if there's some delay or anything. So multiple ways, I think, to cull your list down and that we're available to help you understand how to optimize that process at your own site.
Some sites are doing kind of NLP-like activities because there's something called the adenoma detection rate that is a quality measure, and many big centers are interested in measuring that. And by measuring that, they're effectively identifying people with 1 or 2 non-advanced adenomas. There's no doubt that we could do better in figuring out, for example, how to mine EPIC for the eligible patients. And I think you're right to put that on us, on our leadership, and it's something that we should try to navigate, and we haven't done that yet. But certainly we understand the issue, and hopefully we can help you with it as we go forward.
Hello, my name is Lilith Serrano. I'm from the Puerto Rico NCorp. It's not a question, it's just a concern towards the Spanish materials that are available at CTSU. I thank you, Dr. Sean, because you came in, the emails that we were having with Judy Langer, the regulatory person. I hope you can keep on feeding back on that issue. Supposedly, we're supposed to get those documents by February, but if we can get them like early February, it would be much better. We do have a lot of pre-screened patients for enrolling, so we hope we can, come on and be part of it.
Hi, Judy Langer here. Yeah, we are working on those. We did run into a few issues related to comments that we got back from the IRB. So we are working through those. It certainly has taken us a little longer than we had hoped for. We certainly want our Spanish-speaking patients to be able to get on, and we want to roll out a lot of documents because there are a lot of patient-directed materials, so we do want to roll all those out in a timely fashion here. So we are working through that. We keep you in mind.
I have a couple questions and comments from the chat. So one of the questions that's in the Q&A is, has any site found a good education resource which details the different types of polyps? This could be helpful for coordinators when they screen, as it may be a new area for some to learn. I will say, as an oncology nurse for way too many years, it is a whole new education, and it's something totally different to learn. I ask Dr. Schoen questions all the time. The CCD is in the process of putting together a document which I think went to you for review. It may not have yet. But it's a document about polyps. We're calling it Polyps 101. So that'll be coming out as a tool for coordinators when they're screening potential FORTE patients. Rocky, do you have anything to add about a resource to learn more about polyps?
I think we will get you something that's simple and straightforward. Obviously, you can look on the internet, but it's a little bit of a morass. Now, for us, we know it, we live it, and so we'll try to boil it down for you in a real effective way.
Thank you. Dr. McCaskill-Stevens left a message in the chat, and she stated that the certification processes will be simplified in a few months for the GI physicians, just so everybody's aware of that. Les, do you want?
The main thing to keep in mind.
Leslie, why don't you take the microphone?
The main thing to keep in mind even with the simplification, is if a physician is obtaining informed consent from the patient, they will have to have GCP training or whatever, the training once every 3 years. I will tell you, we all have to do it at NCI. After you do it the first time, the second time, unless you're really brain dead, you can score out of or test out of almost every module because it doesn't change. So if you're not the one obtaining the consent, then it will be incredibly simplified.
Thank you. Dr. Schoen, can you speak to the $40 incentive that you mentioned? There was a question about that in the chat. They're asking, Rocky mentioned some sites providing a $40 incentive. How are they doing that? Do you know if sites providing are providing a gift card, cash, or check? They're trying to figure it out. Do you want to speak to it a little bit?
Yes. First of all, it's not an incentive. It's a travel allowance. It is approved by the CIRB. They're aware of it. It's in our, it's in the major protocol. I will say this, the money it's not on top of your reimbursement. You are taking part of your $1,500 reimbursement, that is $40, and you're setting it aside for the participant as a travel allowance. We found in our site, and as I said, we've already enrolled 70 patients. We would be making appointments, and then we do a lot of work getting all the books together and everything, and then last minute, they don't show. And we realized, from a business standpoint, it behooved us to give this money as establishing our commitment to the participant, and in turn, their commitment to being part of this trial. I believe it's done as a gift card, but now you're getting out of my expertise.
And speaking for the Charleston VA, we are not allowed to pay for time, but we're allowed to pay for travel, and we do it by mileage. That's what we've been approved to do.
VA participation.
Yes, thank you. I wanted to speak about retention. Basically, I looked into participant retention, and found that financial resources contribute to the failure to complete trials and non-compliance, such as cost of travel, childcare expenses, taking time off from work, and also contributing to those are unstable living conditions, low levels of education, and poor social support systems. And speaking for the VA, we have a lot of homeless veterans nationwide. Also, when participants withdraw from a study, it can reduce statistically significant conclusions on efficacy and safety. It disrupts the study stratification schema, aka creates an imbalance in study arms, the 5 years and 10 years versus the 10-year. And finally, the recommended solutions for this, participants participating in a study should bear no additional expense for testing or care, be reimbursed for time and travel in the VA travel, and retention and adherence to the study regimen may be improved by continuity of care, basically constant operations over time, communication style. It's critical to have respect for participants and the participants' time. Personal touches help, tailoring retention strategies to the participants, and having the same study coordinator for initial evaluation, phone calls, and clinic visits. It's really important that they're well-trained, organized, persistent, and they communicate well. And patient retention is enhanced by the clinical trial may reduce the risk of disease, especially in the 5 and 10-year arm, and educational tools. It's the opportunity to create awareness about colon cancer.
Hi, Greg Yothers, University of Pittsburgh and NRG STMC. I noticed in the last session, Dr. Schoen, that your institution was the top accruing LPO for NRG Oncology this past year. I don't believe they were the year before. Does your participation in this study have something to do with that?
Thank you, Greg. And I can tell you that Doug Corley at Kaiser got an award for NCORE recruitment because, as you can imagine, putting 70 patients on treatment trials in a year or less than a year, that's a tall order. And so obviously this is a high volume recruitment, and I can assure you our cancer center is going to tout this, and certainly that's an opportunity for everyone in the room at their centers. I wanted to turn back to Nikki because this has been she's a pioneer it's the first VA that we've had enrolling in the FORTE trial. And I thought it'd be worthwhile for her to address more about how you accomplished that. And we are reaching out to VAs to become a part of this study.
I guess it's a lot of, clearance. It took us about 8 months to get it up and going at the Charleston VA. And we have to run everything by our CIRB, and there are a lot of roadblocks. So basically, if anybody needs to email me, please contact Cheryl, and she'll put me in touch, and I can answer any questions that anybody might have.
And I can say I connected you with somebody today in an email.
Oh, great. Thank you.
I just also want to say, while we've been sitting here, 2 patients have gone on FORTE, so we are at 343 patients accrued.
Could you please circle back to the quality metric that you said big hospitals or big institutions may actually be capturing, because that may help us?
So yes, just to build on what Dr. Schoen said, there is something called an adenoma detection rate. And how you calculate an adenoma detection rate at your center is a system has to already exist that pairs a colonoscopy finding with a pathology report. And so this system is meant to detect any one adenoma on any given colonoscopy. And actually has some indications in there as well. So for example, it will screen out patients who are getting a repeat surveillance colonoscopy and only focus on screening or diagnostic colonoscopy. So other sites that we've worked with, they've been able to use the existing adenoma detection rate software, retune it instead of being purely an ADR software to be a looking for FORTE participant software. So they exclude the big adenomas, they exclude more than 3 adenomas, et cetera. And they've been able to get these pre-generated lists of potentially eligible patients. So that is definitely something to look into, and it's an alternative to using an outside outfit like Pieces to try to find eligible patients. Absolutely.
I just want to add, this is a chance for a little education. The notion is that if you're doing a colonoscopy, you should be finding the polyps that are there. And why? Because we think that finding polyps and removing them prevents subsequent cancer. Well, it turns out, through retrospective studies, we're able to identify that endoscopists who had low adenoma detection rates, lower than expected, meaning that they were likely to be leaving adenomas behind. They weren't detecting them, they weren't removing them. The patients of those physicians had higher long-term cancer rates. So then it became a quality measure. You need to be in people who are, let's say, undergoing screening colonoscopy. It's expected that 30% of the time you're going to find an adenoma. If you only find it 15% of the time, the presumption is you're missing them. And so that's the quality metric, and that's why some hospitals, some systems have evolved, and they're pursuing that because they want to keep a watch on the delivery of care.
Since we have our coordinators here as well, I just wanted to ask if you guys have any kind of tips and tricks on how you talk to patients about the study. If they have any hesitations, questions that you've heard repeatedly? What kinds of things do you do to assure patients that the trial is good for them?
I just had a funny story. We had one patient we reached out to, and a lot of them say, I want to make sure I have that 5-year exam, and this patient was like, heck no, I'm not signing up in case I get the 5-year arm. He didn't want it any sooner than he possibly had, so he was a no-go. But I just think coming down to their level, kind of laughing about it, and just telling them how much you appreciate them. I think that goes a long way, making them feel that they're engaged and that they're doing something really great, actually, and a lot of them get a kick out of that. So I think if you push that it's all about relationships. That's what it comes down to.
Yeah, I have to agree with that. Just being very friendly with these patients. I call all of my patients, so they're not face-to-face. They don't know if I'm some crazy person off the street, so I try to make it as personal as I can. And one thing is my phone number. If you're calling from a phone that does not have your healthcare system on it, that's a huge problem. Another thing that I did notice too is we were sending out letters with oncology written on them, and it made me think, now if I was not in research and I did not know anything about research, oncology, where would it go? Would I open it? No, it would go in the garbage can. So I changed our envelopes to reflect our healthcare system, so they see it and they're like, ooh, it's from my doctor. So it makes it a little more legit. But also talking to the patients, a lot of the questions or feedback that I've had is, well, why would I do this? My doctor said I absolutely have to have a 5-year. And I let them know, you know what? Your doctor has given approval, you're considered low risk. There's a strict eligibility criteria that we need to meet to make sure that you are eligible for this study. And your GI provider has signed off on that, saying that you are okay to do that. So that is one of the huge barriers. Or the other one is, well, okay, sure, I'll go on the study, but now I'm going to get put in the 10-year group. And now, in 10 years, I'm going to come back and it's going to say I have colon cancer, and I could have prevented that. Well, then I let them know, surveillance. It's surveillance. If you need to have one, if you got a tummy ache and your doctor wants you to go have a colonoscopy, absolutely 110% do it. This is surveillance only. We are not going to interfere with that. So I think that kind of eases their mind. But those are the two biggest barriers when I'm calling patients, to kind of ease their mind. And they want to stick to what their doctor said, what their doctor said. So, having that okay from your GI doc. And if they were to call the GI doc, they need to be able to say, yeah, I said it was okay. So I educate my GI departments. I, do refresher meetings with them just to kind of run through the study again, kind of what is it again, what am I doing? So if somebody were to call, they would be like, absolutely, yeah, go on it.
And speaking for the VA, the veterans are just very willing to participate and to help future veterans. They look at it very, being that cancer is so prevalent, that they look at it as a very important cause. They're very giving of their time.
Pay it forward, kind of.
Yeah, it's definitely a pay it forward.
Cheryl, do you want to do your presentation? I am so loud.
Yeah. Hi, I'm Cheryl Liao. I am the FORTE Education and Communication Specialist with NRG Pittsburgh Ops. And I'm hoping that you guys are having a wonderful time in Orlando. It was snowing when I left, so I'm delighted to be here. If you are on social media, I do want to recommend that you use the hashtag NRG2023 to share your insights from this workshop and other sessions that you're having. FORTE has a strong social media presence, so definitely encourage you to interact with us there as well. Today I'm going to be talking about the variety of materials that we have available on CTSU that research professionals can use, in particular to communicate with gastroenterologists, since that is one of the barriers that we found in activating FORTE across the different NRG sites. I'm going to be just reviewing 3 of them today. The first one is this recently created FORTE letter to GI practices. This is a letter developed by NRG staff for you to send to gastroenterologists, endoscopists, and private practices alike to inform them about the trial and encourage them to participate and to contribute referrals to your sites. There's a bunch of fill-in-the-blank sections where you can include your letterhead, personalized contact information both to the person that you are communicating with and, of course, your own contact information so they know who to look back to. And of course, a section where you can include any attachments that would be relevant to them. One of which has already been mentioned today. It is the GI Society's endorsement letter. This is a very important letter for gastroenterologists to read to see that FORTE is in fact endorsed by the American College of Gastroenterology, the American Gastroenterological Association, and the American Society for Gastrointestinal Endoscopy. This is definitely a very strong tool to reassure GI physicians that FORTE is supported by these very important organizations. Another tool that we have created is the gastroenterologist targeted video that we actually recorded at the last NRG meeting. It highlights the need for a definitive clinical trial examining surveillance colonoscopy intervals, particularly for these non-advanced adenomas. This video is about 90 seconds long, should not take up too much of their time. So, instead of, if they prefer not to read a letter, we definitely encourage you to send this video out. It can be found on our YouTube channel, which I'll cover in a few seconds. These are some of the materials we have created to connect you with GI practices for FORTE. And if you want to see more information, we also have some business cards up here with kind of site and GI directed materials. Feel free to come up and get them after the workshop. We also want to ask, though, how else can we help you? The NRG FORTE team and the study team, we are all very happy to meet with you to discuss any personalized strategies for your site in opening FORTE. As you've been hearing, all of our different sites have slightly different methods on how to conduct the trial, so we definitely encourage you to reach out to our email address in particular, and we will be happy to meet with you and figure something specific out. Now, to pivot to some communications activities. As I previously mentioned, FORTE now has a YouTube channel. We definitely encourage you to get on there and see the different presentations that have been done across the NRG meeting and some videos that we have created as well. We're excited to create more content throughout this NRG meeting to promote FORTE with research professionals to increase the visibility of this incredibly crucial cancer prevention trial. We are also active across multiple social media platforms, so would encourage you to connect our accounts with your sites. Many of your sites actually have social media accounts. Actually, in particular, the Metro Minnesota group is always on Twitter, and we can definitely use materials that we have created to encourage more visibility of the FORTE trial. To ask the question, how else can you use social media? Colorectal Cancer Awareness Month is actually coming up really soon. It is in March of this year, and I definitely encourage you all to be following the FORTE accounts and to be using the hashtags above. We are creating lots of materials that will be available through CTSU once we get CIRB approval for the use during Colorectal Cancer Awareness Month. This will be a great opportunity for you to use these hashtags and, among others, to integrate with existing dialogue on colorectal cancer, especially with the many advocacy groups that are out there, and especially the patient advocates who are very dedicated to this cause. And I just want to remind you again to not forget to use the hashtag FORTEstudy to ask any questions that you have. If we don't get to answer all of them today, the study team will be answering them on Twitter. So thank you so much for being here. I will turn it back over to the concluding portion of our FORTE workshop today.
It is 2:30, so we likely have lost the virtual component.
Well, we have to have Lisa Kachnik come up here and give us her final charge.
And so those lights are really bright. So low-risk adenomas don't discriminate. I just had a upper endoscopy. They threw in a lower, and I am a candidate for the FORTE trial. So this is a super important trial. We still have 9,300 patients to accrue and really need to do it over the next few years. It's encouraging that our enrollment is increasing, but we need you to help us answer this question. So I think this was a wonderful session. I love the panel discussion. Please reach out to us if you have other questions on how we can help you enroll to this important study. Thank you.